Hello, today's lesson is about manifestations of liver disease. When we see the pathologic manifestations of liver disease, congenital and acquired alterations in hepatic structure and function, acute or chronic, can be manifested by varying pattern of reaction of the liver to cell injury. Hepatocyte injury can be caused by viral infections, drugs or toxins, hypoxia, immunologic and structural disorders, or inborn errors of metabolism. The injury results in inflammatory cell infiltration and cell death, which might be followed by healing process of scar formation and potentially nodule formation or regeneration. Cirrhosis is the end result of any progressive fibrotic liver disease. Cholestasis is an alternative or concomitant response to injury caused by extrahepatic or interhepatic obstruction to bile flow. Substances that are normally excreted in bile, such as bile acids, conjugated bilirubin, cholesterol, and trace elements, accumulate in serum. Causes include alteration in enzymatic or canalicular transport activity, permeability of the bile canalicular apparatus, organelles responsible for bile secretion, or ultrastructure of the cytoskeleton of the hepatocyte. The end result might be clinically indistinguishable from obstructive cholestasis. Cirrhosis is defined histologically by the presence of bands of fibrous tissue that link central and portal areas and form parenchymal nodules. It is an end stage of any acute or chronic liver disease. Cirrhosis can be macronodular, micronodular, or mixed forms. Macronodular with nodules of up to 5 cm separated by broad septa. Micronodular with nodules of uniform size, mainly less than 1 cm separated by fine septa and mixed forms. The progressive scarring results in altered hepatic blood flow with further impairment of liver cell function. Increased intrahepatic resistance to portal blood flow leads to portal hypertension. And the liver can be secondarily involved in neoplastic and non-neoplastic, such as storage disease, fat infiltration process, as well as a number of systemic conditions and infectious process. The liver can be affected by chronic passive congestion, such as CHF, or acute hypoxia with hepatocellular damage. When we see the clinical manifestations or the peripheral stigmata of the liver disease, the first one is hepatomegaly. Enlargement of the liver can be caused by several mechanisms, and normal liver size estimation are based on age-related clinical indices. In children, the normal liver age can be felt up to 2 cm below the right lower costal margin. In a newborn infant, extension of the liver age more than 3.5 cm below the costal margin in the right midclavicular line suggests hepatic enlargement. Measuring of liver span is more reliable than an extension of the liver age below the right lower costal margin alone. The liver span increases linearly with body weight and age, ranging from approximately 4.5 to 5 cm at 1 week of age to approximately 7 to 8 cm in boys and 6 to 6.5 cm in girls by 12 years of age. The lower edge of the right lobe of the liver extends downward and can normally be palpated as a broad mass in some people. An enlarged left lobe of liver is palpable in the epigastrium of some patients with cirrhosis. Downward displacement of the liver by the diaphragm due to hyperinflation or thoracic organs can create an erroneous impression of hepatomegaly. Examination of the liver should note the consistency, contour, and the tenderness, presence of any mass or bruits, assessment of spleen size, and the presence of ascites and any stigmata of chronic liver disease. Ultrasound is useful in assessment of liver size and the consistency, as well as gallbladder size. Gallbladder length normally varies from 1.5 to 5.5 cm in infants to 4 to 8 cm in adolescents, with ranges from 0.5 to 2.5 cm for all ages. Gallbladder distension might be seen in infants with sepsis, and the gallbladder is often absent in infants with biliary atresia. The other peripheral signs of liver disease, jaundice or icterus. Yellow discoloration of the sclera, skin, and the mucous membrane is a sign of hyperbilirubinemia. Clinically apparent jaundice in children and adults occur when the serum concentration of bilirubin reaches 2 to 3 mg per dl, whereas in neonates it appears when it reaches more than 5 mg per dl. Jaundice may be the earliest and only signs of hepatic dysfunction. Liver disease must be suspected in the infant who appears only mildly jaundiced but has dark urine or alcoholic or light colored stools. Immediate evaluation to establish the cause is required if the child is jaundiced. Measurements of the total serum bilirubin concentration allows quantitation of jaundice, and the bilirubin occurs in plasma in forms: unconjugated bilirubin, free or unbound bilirubin, conjugated bilirubin, and delta bilirubin. The delta fraction permits conjugated bilirubin to persist in the circulation and delays resolution of jaundice. Although the terms direct and indirect bilirubin are used equivalently with conjugated and unconjugated bilirubin, this is not quantitatively correct because the direct fraction includes both the conjugated bilirubin and the delta bilirubin. Unconjugated hyperbilirubinemia might indicate increased production, hemolysis, reduced hepatic removal, or altered metabolism of bilirubin. Whereas conjugated hyperbilirubinemia reflects decreased excretion by damaged hepatic parenchymal cells or disease of the biliary tract, which may be a result of obstruction, sepsis, toxins, inflammation, and genetic or metabolic disease. The other signs of liver disease is pruritus. Intense generalized itching can occur in patients with chronic liver disease, often in association with cholestasis. Symptoms can be generalized or localized. Symptoms can also be worse usually at night, and they are exacerbated with stress and heat and are relieved by cool temperature. Pruritus is unrelated to the degree of hyperbilirubinemia, and its deeply jaundiced patients can be asymptomatic. The pathogenesis of pruritus remains unknown. However, multiple suspected pruritogens have been reported, including bile acids, histamine, serotonin, progesterone metabolites, endogenous opioids, lysophosphatic acid, and lysophosphatic acid forming enzyme called autotoxins. The other peripheral stigmata of liver disease is spider angiomas. Vascular spiders or telangiectasias, which is characterized by central pulsating arterioles from which small, wiry venules radiate and may be seen in patients with chronic liver disease. These are usually most prominent in the superior vena cava distribution area, for example on the face and the chest, and their size varies between 1 to 10 mm and they exhibit central clearing with pressure. This presumably reflects altered estrogen metabolism in the presence of hepatic dysfunction. So this is an image of spider angioma. The other peripheral stigmata of liver disease is palmar erythema, blotchy erythema, most noticeable over the tenar and hypotenar eminences and on the tips of the fingers, is also noted in patients with chronic liver disease. Abnormal serum estradiol levels and regional alterations in peripheral circulations have been identified as a possible cause. The other is Xanthomas. The marked elevation of serum cholesterol levels associated with some forms of chronic cholestasis, especially Alagille syndrome, can cause the deposition of lipid in the dermis and the subcutaneous tissue. Brown nodules, which can develop first over the extensor surface of the extremities and rarely xanthelasma over the eyelid develops. The other is portal hypertension. Portal hypertension occurs when there is increased portal resistance and or increased portal blood flow. The portal system drains the splanchnic area, that means abdominal portion of the GIT, pancreas, and the spleen into the hepatic sinusoids. Normal portal pressure is between 1 and 5 mm of mercury, whereas pulmonary hypertension is defined as portal pressure greater than or equal to 6 mm of mercury, but clinically significant portal hypertension exists when pressure exceeds the threshold of 10 to 12 mm of mercury. Portal hypertension is the main complication of cirrhosis, directly responsible for two of the most common and potentially lethal complications, ascites and variceal hemorrhage. The other is ascites. Ascites is a consequence of increased hydrostatic and osmotic pressures within the hepatic and mesenteric capillaries, resulting in transfer of fluid from blood vessels to the lymphatics that overcomes the drainage capacity of the lymphatic system. Factors favoring the intra-abdominal accumulation of fluid include decreased plasma colloid osmotic pressure, increased capillary hydrostatic pressure, increased ascitic colloid osmotic fluid pressure, and a decreased ascitic fluid hydrostatic pressure. The other is GI bleeding. Chronic liver disease may manifest as GI bleeding, which might result from portal hypertensive gastropathy, gastric antral vascular ectasia, or varix rupture. Variceal hemorrhage is classically from an esophageal origin, but might be caused by gastric, duodenal, peristomal, and rectal varices. Variceal hemorrhage results from increased pressure within the varix, which leads to change in the diameter of the varix and increased wall tension. And when the variceal wall strength is exceeded, physical rupture of the varix results. Given the high blood flow and the pressure in the portosystemic collateral system, coupled with the lack of natural mechanism to tamponade variceal bleeding, the rate of hemorrhage can be striking. The other is encephalopathy. Hepatic encephalopathy can be manifested as any neurologic dysfunction, but is most likely to present in subtle forms such as deterioration of school performance, sleep disturbance, depression, or emotional outbursts. It can be recurrent and precipitated by intercurrent illness, drugs, bleeding, or electrolyte and acid-based disturbances. The appearance of hepatic encephalopathy depends on presence of portosystemic shunting, alteration in the blood-brain barrier, and interaction of toxic metabolites within the central nervous system. Postulated causes include altered ammonia metabolism, synergistic neurotoxins, decreased cerebral oxygen metabolism and blood flow, false neurotransmitters with plasma amino acids imbalance. The other is renal dysfunction. Systemic disease or toxin can affect the liver and the kidneys simultaneously, or parenchymal liver disease can produce secondary impairment of renal function. In hepatobiliary disorders, there might be renal alteration in sodium and water regulation, impaired renal concentrating ability, and alteration in potassium metabolism. Ascites in patients with cirrhosis may be related to inappropriate retention of sodium by the kidney and expansion of plasma volume, or it may be related to sodium retention mediated by diminished effective plasma volume. Hepatorenal syndrome is defined as functional renal failure in patients with end-stage liver disease. The pathophysiology of hepatorenal syndrome is related to splanchnic vasodilation, mesenteric angiogenesis, and decreased effective blood volume with resulting decreased renal perfusion. The hallmark is intense renal vasoconstriction, which is mediated by hemodynamic, humoral, and neurogenic mechanisms with coexisting systemic vasodilation. The diagnosis of hepatorenal syndrome is supported by the findings of oliguria, characteristic pattern of urine electrolyte abnormalities such as urine sodium less than 10 milliequivalent per liter, fractional excretion of sodium less than 1%, urine to plasma creatinine ratio of less than 10, and the normal urinary sediment. And also it is supported by absence of hypovolemia and exclusion of other kidney pathology. The best treatment for hepatorenal syndrome is timely liver transplantation with complete renal recovery expected. The other is pulmonary involvement. Hepatopulmonary syndrome is characterized by the typical triad of hypoxemia, intrapulmonary vascular dilatation, and liver disease. There is intrapulmonic right to left shunting of blood resulting from enlarged pulmonary vessels that prevents adequate exposure to oxygen-rich alveoli of red blood cells traveling through the center of the vessel. Shunting of vasodilatory mediators from the mesenteric away from the liver is thought to contribute for this. Hepatopulmonary syndrome should be suspected and investigated in a child with chronic liver disease with history of shortness of breath or exercise intolerance, and clinical examination findings of cyanosis, clubbing, oxygen saturation less than 96%, particularly in the upright position. Treatment is also liver transplantation, and the resolution of pulmonary involvement typically follows. Portopulmonary hypertension is a condition characterized by an increase in the resistance to pulmonary arterial blood flow in the setting of portal hypertension. It is defined by a pulmonary arterial pressure more than 25 mm of mercury at rest and above 30 mm of mercury with exercise, elevated pulmonary vascular resistance with pulmonary arterial occlusion pressure, or left ventricular end-diastolic pressure of less than 50 mm of mercury. Although the pathophysiology is unclear, deficiency in endothelin prostacyclin synthase and increased circulating endothelin-1 have been implicated as a cause for the vasculopathy. Symptoms suggesting a diagnosis include exertional dyspnea, fatigue, syncope, palpitation, and chest pain. Pulmonary arterial directed therapy is the cornerstone of management, along with consideration of liver transplant. The other is recurrent cholangitis. Ascending infection of the hepatobiliary system is often seen in pediatric cholestatic disorders, most commonly because of gram-negative enteric organisms such as E. coli, Klebsiella, Pseudomonas, and Enterococcus. And the liver transplantation is the definitive treatment for recurrent cholangitis, especially when medical therapy is not effective. When we see miscellaneous manifestations of liver disease, non-specific signs of acute and chronic liver disease include anorexia, abdominal pain or distension resulting from ascites, spontaneous peritonitis, visceromegaly, malnutrition and gross failure, and also bleeding. Bleeding might be a result of altered synthesis of coagulation factors, biliary obstruction with vitamin K deficiency or excessive hepatic damage, or to portal hypertension with hypersplenism. In the presence of hypersplenism, there can be decreased synthesis of specific clotting factors, production of qualitatively abnormal proteins, and alteration in platelet number and function. Altered drug metabolism can prolong the biologic half-life of commonly administered medications. This is all about the stigmata of liver disease. Thank you for listening.